I will present you syndromic surveillance among migrant population in Republic of Serbia 2015-2016. Since 2015, Serbia has been faced with a sudden increasing in migrants. According to the data provided by the UNHCR, okay, it's better. Okay. According to the data provided by the UNHCR, on the end of June 2015, between 600 and 1,000 people a day entering in Serbia. But increasing number of people was notified during since 2014. For example, in 2014, were issued 3 times more certificates of intent than in 2013, and 6 times more in 2015. Most of these people comes from Syria and Afghanistan, and less of them came from Somalia. Serbia was found on Eastern Mediterranean and Western Balkan migrant transit route, as increasing number of migrants crossing from the Greece to the former Yugoslav Republic of Macedonia, and additional to the Serbia, towards to the Central European countries. These people were concentrating on the area with inappropriate living condition and sanitation facilities. They illegally crossed the border and stayed in the country for a maximum 3 days. But data after the end of February 2016 varied. This situation opened the possibility of importation of some infectious diseases, including public health concerns. In that time, medical procedures for migrants in asylum centers was already in place, but majority of that people in transit was not residents of these centers. On the entrance of the country, were established some control measures. National authorities established on the entrance of the country the first time on the border with the former Yugoslav Republic of Macedonia, and later on the border with Bulgaria, reception centers for newly arrived migrant population to ensure health assessment and to registration immediately upon arrival. Also, the adequate shelter with good sanitation facilities were established. To undertake control measures, National Institute of Public Health launched on 3rd September 2015 a syndromic surveillance. Also, the multidisciplinary surveillance coordinating team were defined on the national and also on the district level. The purpose of that teams is to coordinate activities in order to monitor disease trends, to implement control measures, and to detect outbreaks. The objective of my study is to estimate the monthly incidence of syndromes in order to assess the burden of communicable diseases in migrant population from week 37 2015 to week 19 2016. Population under surveillance is migrant populations. It means asylum seekers and irregular migrants who pass border with the former Yugoslav Republic of Macedonia and with Bulgaria and registered on the reception centers. Cases are reported according to the defined case definition for a set of these 9 syndromes. This study is descriptive analysis of surveillance data from week 37 2015 to week 19 2016, and cumulative monthly incidence was calculated, which means the number of cases per 1,000 migrant population. Due to implement some standard procedures for collecting and managing data, National Institute of Public Health developed guidelines with the procedures and methods of collecting and managing data, which was distributed through the whole country on this September 3rd, 2015. Collecting data started on the reception center. Data of number of migrant population comes from Commissariat for Refugees, and data of number of syndromes was provided by the medical staff from ambulance on the reception center. Field epidemiologist from District Institute of Public Health was collecting and aggregating data by week and transmitted these data for previous week by the web-oriented application to the National Institute of Public Health. And finally, the National Institute of Public Health prepared reports, weekly reports, with, which was include some epidemiological situation, and distributed these reports to the Ministry of Health and come back to the District Institute of Public Health. The main results of mine study is that the total number of migrant population is more than 500,000 people, with monthly mean of around 58,000, ranging from 158 to more than 133,000. Total number of registered syndromes is around 12,000, with monthly mean of 1,422, ranging from 131 to more than 2,000. The most common registered syndromes are respiratory infections, with 74.7% of total, and cumulative incidence of 18.18 per 1,000 migrant population. And second most common registered syndromes is acute watery diarrhea, representing 13.4% with cumulative incidence of 3.2 per 1,000 population. Meningitis, encephalitis, Russian fever, and fever and bleeding are not registered syndromes. Also, there is no registered outbreaks. Behind the most common registered syndromes, so on this table you can see the other registered syndromes. Non-blooded gastroenteritis representing around 6% of total, and acute watery respiratory tract infections and unexplained fever representing around 3% of total. This graph shows the number of migrant population and cumulative incidence of all registered syndromes. You can see that while the number of migrants population decreasing over the time, cumulative incidence rate is essentially stable up to period 8 to 11 week, with sharply increasing thereafter. On this graph, I show you incidence of most common registered syndromes. The occurrence of most common registered syndromes shows a similar pattern. Also, the incidence of most common registered syndromes are essentially follow the trends of cumulative incidence of syndromes that were under surveillance in the respective time of period. The most common registered syndromes included respiratory infections and acute watery diarrhea, which is in line with the findings in literature. Although the syndromic surveillance system has been successfully implemented in a number of emergency situations, its application was not widely documented in the context of migration. Occurrence of most common registered syndromes shows the similar pattern, and it was essentially stable from week 37, 2015 to week 8, 2016, which can be explained by the seasonality and inappropriate living conditions. But sharp increase after week 11, 2016 need a further investigation. Outbreaks were not registered, and that can be good indicator that there is no increasing risk of communicable diseases. The limitation of my study is different sources for data of migration and migrant population and cases. And second limitation is that there, since of February 2016, duration of stay varied. Recommendation. Periodical evaluation of syndromic surveillance system, particularly for those who is urgent implemented. Due to better understanding and describing the data, the syndromic surveillance system should be improved in terms of defining age groups and determining the weekly thresholds for alert for more frequent syndromes. But primary prevention of communicable diseases should be on rapid providing good living conditions and sanitation facilities, health assessment, healthcare access nationwide, and health education and health promotion. And finally, I would like to thank the whole health professionals and other key partners who was involved in managing migrant population. Also, I would like to thank my past director, Dr. Dragana, and sorry. And MediPIET team to give me opportunity to participate in MediPIET activities. And particularly, I would like to thank to my supervisor, Mitra Drakulovic, and especially my, sorry.
Thank you, Dragana.
To my scientific coordinator, Nicoletta Mavredi. Sorry. And thank you for your attention.
Thank you, Dragana. It was very interesting. Thank you. So I will have to open the floor for 3 or 4 questions. Maybe we'll start with you. We will need you to identify yourself and then to ask your question. She will give you.
Thank you for your presentation. It is an obvious and clear. I want to ask very important issues about the main. I am Mr. Ibrahim Salim. I am the Director of Public Health Laboratory in Palestine. I want to ask important questions about the main causes of the respiratory infections, which are the main viruses you isolated, and also what are the main causes of the diarrhea. Watery diarrhea, maybe viruses, I don't know, maybe parasites, maybe bacteria. You have some information or data about this?
Yes. Yes, thank you for your question. I understand very well. And as I mentioned, we are managing the trans-immigrant population which stayed in inappropriate living condition during a long time period. They crossed from Syria to the Turkey and to the Greece, and when they come in Serbia, there's very exhaustive, and I think and they transit in overcrowded. And I think that is the main reason because we have the most frequent syndrome, respiratory infections, and diarrhea. We haven't. This is the suspected cases. This is suspected cases. We didn't work on
laboratory confirmation.
Syndromic cases. Yes.
That's syndromic. Thank you. So now we have Majd.
Hi, thanks for your presentation, Dragana. So I'm Majd Saleh. I'm a MediPIET fellow. Looking at the week numbers, I noticed that they coincide between September and May. September 2015 and May 2016.
Yes.
So the question is, since this is usually the season for respiratory infections and influenza, does it coincide with what you saw in Serbia, in the surveillance system in Serbia.
Yes, we
especially
have.
after week 11, where you said that there was a sharp increase.
Yes, we
that's my
have.
question.
Yes, thank you, Marsh. In Serbia, yes, the season for influenza is from 14 epidemiological week to the 20 epidemiological week. And I think that some respiratory infections could be associated with influenza, but that people transit through Serbia for the very short time period. We didn't make additional investigation of that cases.
I think the question also needs, do you have the same pattern in the Serbia population than for this population, or it's a different pattern? This is the question, I think, for Mesh.
Yes, the first cases in Serbia influenza was registered in this period, November, December, and incidence of influenza cases increase. And I think that peak is in April. No, March. Yes.
Okay. So it was similar pattern throughout
Yes.
the population.
Yes.
Okay. Okay. Thank you. Okay. We have 1, 2, and 3 questions. So.
Thank you. I'm Dr. Yasser from Palestine. You put two syndromes in the way you are assessing the migrants. One is acute respiratory infection, and the second is lower respiratory infection.
Yes.
And how did you distinguish between them syndromically?
We have defined definitions for respiratory infections. For acute lower respiratory infections, case must have problems with breathing, and must be to have dyspnea. It is distinguished among respiratory infections and respiratory. Yes. Lower, sorry. Yes.
So the lady there. The lady, and you finish with him. The best to the end. So it's okay? Okay. So you can go for it.
Thank you. Thank you for a very, very nice presentation.
Thank you.
Just 2 comments. And one, I mean, this really shows the importance of regarding migrants as primarily healthy people, and the importance of providing good conditions so that they are not getting infected when reaching the new countries. But the other is, you were saying that you wanted to improve the system and looking at threshold. So this is just for information that ECDC very, very recently published a technical report on how to monitor infectious diseases among migrants, and how to calculate the thresholds, and how to do this. So for those, and I know that this is a big problem in many countries of the region. So this was done by our colleagues in Italy, with great input from our colleagues in Greece and others. So it's worth to maybe have a look at the ECDC website. It's called Monitoring Infectious Diseases Among Migrants. Thank you.
Thank you for this.
Thank you
important
very
input.
much for this comment. We notice and pass through this notebook. Thank you.
So last
very good
question,
job,
yes.
and I just want to ask you about why
can you
you
tell your
didn't
name?
include bloody
Sorry,
diarrhea.
can you tell your name?
Bloody diarrhea.
Silvia Bino from the Institute of Public Health in Albania.
Yes.
Among migrants, because there are data about shigellosis in migrants. And the other thing, the second question is, you are using also syndromic surveillance in Serbia. So how do you see how do you compare your data with the data from syndromic surveillance in the country?
Okay. Thank you very much for questions. We didn't include bloody diarrhea at the second time, but it was proposed to the national authorities by the epidemiological department at the first time. The main reason, I don't know why they didn't conclude that it's bloody diarrhea is the good thing to follow. And second, in my country, we have we developed a guideline for early warning and response system. Also, we have very good experience in emergency situation during the flooding in 2014, and during this situation, we try to find distinguish about first emergency situation and second, which was the migrant crisis in Serbia.
Thank you.